按下去了。
Good evening, ladies and gentlemen. I'm Wei Zhang. On behalf of the Association of Dental Sciences Taiwan, to welcome all of you to join this online symposium today. And today we just plan to discuss about the situation and the challenge in the future in the dental education, research, and in the clinic. So today we invited a lot of the very important speakers to share their experience to us. So firstly, we would like to thank all of your participation, and I wish all of us can have a very good experience today. So now we would like to welcome our first moderator, Professor Minlun Xu, to give us introduction to our first section.
Okay, thank you, Mr. President. Hello, everyone. My name is Alan. I'm very glad to see all of you are in good health condition, even under the severity of the pandemic. Glad to see so many friends from Italy, from Canada, from Japan, and also from
Egypt.
Oh, Egypt. Okay.
Yes.
Friends from
Indonesia.
Indonesia. Okay.
Yeah.
Yeah. So and also from Philippines. And I'm the moderator of the first session, and it is a great honor for me to introduce you the first speaker. The first speaker is Professor Corrado Paganelli. And Corrado, Corrado, say hello to everyone. Yeah, okay. Corrado, Professor Corrado Paganelli, and he is now currently the Dean of the School of Dentistry, Brescia University, Italy. And he's the immediate past president of ADEE, and also he was the chairman of the board of committee IFDEA, International Federation for Dental Education Associations. And Corrado will give us a lecture regarding the IFDEA network and the sharing of e-learning opportunities in post-COVID times. Corrado, please.
Thank you. I'm almost ready. So I think I try to start sharing the screen, if you allow me. Alan, I think I'm allowed. So I share. And I project.
Yes, we can hear you. We can hear you, Corrado.
And I think you can see my first slides, just to thank Alan for this wonderful opportunity. I think that collaboration can start only if we see each other. So thank you so much for this opportunity. We desperately need to have as many and as short as possible of these type of webinars. These are the two main concepts I would like to spend today. So, of course, we are with a huge amount of webinars from everywhere in the world, and we can choose. What we see is that our colleagues are sometimes fed up of the long type of webinars. So I thank you so much, Alan, because this is tuned to be with 20 minutes. So if you don't mind, I just skip all the bureaucracy, saying that, of course, these are my opinions, and of course, they are not reflecting organizational point of view. So this has to be clear. So just go back to what is my main message. Italy is not homogeneous. Europe is extremely varied in terms of policy and data collection. And of course, we are all aware that COVID is still changing. So what we need is to have a double check of our sources of information. But I think that we share most of the consideration and the scientific consideration and the evidence-based support, because what I show here is the CDC of Atlanta keynotes. And I think that these are what we are using everywhere in the world. I'm just saying these are not the Italians one, but they are homogeneous with this. So what about Italy? I am based in Brescia, that is exactly in the location of the first outbreak in Italy. So we are an area of 1,200,000 inhabitants, very rich in terms of economic support, and Lombardy, that is this gray area on the long Italy, is 10 million inhabitants. So you can easily understand that what happened up here is not homogeneous to what is happening in Sicily, because of different spread of the pathology, but different attitudes of the population. I recommend to use WHO report to understand what is exactly happening in Italy, if you are interested in one single area. I'm quite satisfied to show this, that is clearly stating that the fact that we started on 21st of February with the first person that was dying in Italy. We reached the peak and now we are going down. Are we going down, or is the effect of a 7-day moving average graph that I'm using? Of course, the second, because it's not something that you can delimit in a very fast way, just day by day. In particular, because the swaps are really dishomogeneous in terms of what are the red zones, what is the governmental decision to concentrate epidemiological data, and what is the population exposed, how the population is moving. Is this reflecting dentist? Yes, because also different countries had different approach. For example, Italy has no law imposing to shut down dental practice, but it was an unethical decision by the order, by the General Dental Council, by the association, to reduce any activity that was dangerous for the population. This has induced also dentists to donate PPE for general practice, for human medicine, for what was on the territory. Dentists were involved also in providing information. In some countries, dentists were involved also in swab, and so they were exposed. This is not the case of Italy. So you might have read that 16 dentists died. Yesterday, I had a very interesting webinar with the International College of Dentists, and Germany was pointing out clearly that dentist is a safe profession. And I think we have to go on with this message, because most of the countries around the world are going back to normal or minimum to unlocking. So we have to spread the information that dentists have always behaved in the right way. So there is no huge problem on this. Sorry if I'm fast, but I think that we can go back to main points if something is important. On the other aspects, of course, hospitals or hubs where COVID positive patients were concentrated in some countries were going on with undeniable treatment because this was needed. In particular, to avoid patients to go to the general emergency department for anything else that was not COVID, in order not to have too many patients in the general emergency departments. So to go back to my own Brescia school, we closed down everything on 21st of February for postgraduate students, and undergraduate students were cut off of the school at all. We decided to use only senior staff in order to reduce the social life contacts of the youngsters. And we have sent back all the visiting students, all the people that were here not for assisting patients. This was the mandatory aspect. Another aspect of my own small school is that we are providing emergency service to the community, and we constantly received in this way PPE without any problem, because we were serving population. And I must admire our general administrators that have done this in the right way with the right timing. This gave us also the feedback of the need of this type of service by dental schools, if it is possible, dental hospitals for sure. And so we are going back to what was my previous sentence. I'm also a chief dental officer for Italy. I was the past president of the Council of European Chief Dental Officer. And so I'm aware that Sarah Harley, the chief dental officer from England, has asked COVID positive patients to be addressed to hubs where there was no special use of COVID, of PPE for anti-COVID, but there was the correct type of treatment in terms of fear reduction for the normal population. So normal population was aware that the COVID positive patients were going in a special position. And of course, all the remaining dental practices were treating the patients as we have always done with the HIV patients. We are not aware if they are HIV positive or not, and we are treating all the same patients with all the risk management as we know. And my last point on my slide, lay people was scared in Italy and preferred to postpone, but the phone contact was felt needed and useful. So dental education has to work on increasing the teledentistry for sure for the future. What about dental schools in Europe? We have conducted a list of different surveys in order to understand management, governmental, and structural changes. So the data about that are quite easy to foresee. We agree, most of us agree that we are changing dental education for the future and health workforce preparation for the future. But also that we need, during this type of events, psychological support by the school or by the university. Of course, we have been limited in our access to the school and to the regulations, because most of the time we had to apply national guidelines. And as I said before, COVID has determined an overall spreading of the problem, but with regionalization in most of our countries. So, governmental decision, I would like to start with the European Chief Dental Officer meeting that was just on those days in Zagreb. I thank so much Croatian colleagues that have started this in the right way, taking care of the fact that we have postponed almost all in-presence events. If you remember, we have postponed IADR, and the American colleagues have already announced that the next ADIA meeting will be virtual in March 2021. Of course, we have to refer to WHO and FDI to get the overall perspective on dental practice. And in particular, now that we have the pressure by most of the governments to go back to normal activity and to detect what we have. So operative indications by governments on dental and hygienist activity are present almost everywhere in the same way. So if we need any suggestion, I think that we can get all the advice on this without any problem. But what I think is more important is to think to what next. And the fact that most of our university had a period of no promotions, delays in career pathways, and we are already seeing a change in students' choice for admission of professions that require close contact. We have to not advertise, but minimum clarify what is the real impact of dentistry and the impact of COVID in dentistry. So it's not only what is happening already with the last miles of personal mobility that is important. We have to rethink the entire chain. It's not only what is air conditioning, one-way circuit of the patients and the staff in the school, but it's the fact that maybe the haptics and the interaction of tutor and students by technology is not one single piece, but is part of what we have to consider globally. And planning ahead, as today will be addressed by so relevant speakers after me, is possible if we have a collaborative approach. So I think that even this Zoom to hold a webinar is one example. Of course, this is not regionalized because Alan has invited a lot of very important guests, but my idea is that we have to think again how we can move on. And I think that short webinars are the way we have to consider in order to agree on next steps. And for this reason, I think that everybody could remember that the asteroids that were appearing 1 month ago was already seen as a face mask wearing asteroid, but change in habits has already happened, clearly. Believe me, this is Italy, is not UK. So this is a superordinate line in front of a general purpose store. As you see, people had fear, and we have to consider that dental education has to take into account this. We don't have one single solution, but for sure, what we need is to consider this dishomogeneity, heterogeneity, and to provide some good examples that, of course, in my view, cannot be webinars only, because I think that most of us had smart working, and so back pain because of not moving as we were used. Of course, I'm joking, but this was, Alan, my last slide to say thank you for inviting me. Really ready to discuss and go on with a collaboration in this view. And if there is available for this type of coordination and collaboration. Thank you so much for giving me this opportunity. I stop sharing, but I'm ready to accept any question and answer, I think, on the button that is underneath us. Is everything correct, Alan? Or Isabel?
Okay, thank you, Corrado. I totally agree with you that to face the challenge of this COVID-19, I think international collaboration is much important than before. Yeah, and today I noticed that some of our friends from different countries like Switzerland, Professor Sandro Pala from University of Zurich, Switzerland, and Professor Guang Hong from Tohoku University, and many friends are here. And Corrado, may I have a question? And
Please.
Because I noticed that the severity of the pandemic in Italy seems quite severe. And do you think, is it possible it is related to the super-aged society of Italy?
Thank you, Alan. For sure, that one is one easy answer. We are starting to investigate on pollution effects. So, of course, we know that Italy was the first country to be touched. And so, of course, Germany was in an easier position because the intensive care units were already prepared and they were in a higher number. So, of course, what you said about age of the dentist is also clarifying that these 16 dentists dead in Italy are not dead in practice, in dental practice. They were usual human medicine doctors that were postgraduated in dentistry. So the age was over mine. So yesterday we were joking about the fact that I don't know if Isabel is considering me aged or not. So of course I'm a male, so this is easy, but the issue is that I'm the first one in Italy to be graduated before in dentistry and then in medicine, while usually in Italy it was the reverse. So our colleagues were, of course, elder than me.
Hello, Dr. Corrado. This is Professor Sam Sabranaka, previous dean from Hong Kong. Hello.
Nice to see you. Nice to see you, Sam.
Yeah, okay, Dr. Corrado, yeah. So you can hear me. Now I'm in Dubai. Actually, I'm locked in Dubai. But I wanted to ask you a very interesting question. So when you say these 16 dentists died, and you know, it gives kind of a false impression. So did anybody, any healthcare worker in dentistry get impacted by the infection?
Yes, two colleagues in Brescia were infected, but not in practice. They were infected in the area. So, and they were quite young, I must admit. So the problem is that the dentists that were infected in this area were in the most concentrated infection area of Brescia and Bergamo zone. So the two names that you can check on the list in my slides, there is the list by the order. So it's easy to have access to these data. The two dentists were living exactly on the border between Brescia and Bergamo. That is really the most infected area. Sam.
Yeah, thank you very much, Dr. Corrado. So I heard actually.
Thank you for the question, because this is what we want dental education to consider and to spread everywhere.
Yeah, because I saw in a Dental Tribune article recently that some dentists were infected in Indonesia, but it was a very anecdotal report, and I don't know whether that is correct or not. And I don't know whether colleagues from that part of the world can enlighten us on this particular issue. Okay, thank you very much, and thank you, Alan, for arranging this fantastic symposium. Yeah, I'll be listening. Yeah, thank you.
Thank you. Yeah, now we have to move to the next session, and the moderator is Professor Deng. Dana Deng, yes.
要先放那一张啊，先放亚瓦卡的。Okay, we would like to invite next speaker from Japan, Professor Yasutaka Yawaka. He is the Dean Professor of the Hokkaido University of Faculty of Dental Medicine. Today he will give us a speech about the title will be the influence of COVID-19 infection in dental education in Japan, current situation and measures. Hello. Professor Yawaka? I cannot see you. Excuse me. We have a little bit technical problem. Professor Yawaka?
Okay.
Please start your speech. Thank you.
Thank you.
We cannot hear you.
Thank you, Professor Najun Ken. And thank you for invite President Chan and President Allen. Good afternoon and good evening, ladies and gentlemen. I'm Yasutaka Yawaka, Faculty of Dental Medicine, Hokkaido University, Sapporo, Japan. I'm very honored to take part in online symposium post-COVID-19 challenges in dental education, research, and clinical activities. Just on bridge, I take the slide. Okay, today I would like to show influences, current situation, and measures of COVID-19 infection in dental education in Japan. Slide shows COVID-19 infection in Japan. Japan is the eastern part of Asia here. Japan has the traditional face as Kinkakuji Temple and Osaka Castle, and the modern face as Tokyo Skytree. Therefore, I think Japan is fascinating. But patients with COVID-19 infection increased in April. Japanese government decided emergency declaration in 7 prefectures as Tokyo, Kanagawa, Osaka, and so on April 7. And then Japanese government decided emergency declaration in Japan on April 16th. The streets were quiet. The streets are very quiet. And effects of emergency declaration showed the decrease of patient number. Japanese government decided cancellation of emergency in Japan on May 25th.
Professor Yawaka?
Yeah?
Professor Yawaka,
Hi.
actually we cannot see your PowerPoint.
Yeah, oh?
Oh, yes.
Okay. Okay. Okay.
It's
Okay.
okay. It's
Thank
fine.
you.
Yes.
Yeah, continued. COVID-19 infection has settled down after a busy period, and society tended to return to normal gradually. And just now. Next slide shows COVID-19 infection in Hokkaido. Hokkaido Prefecture is the northern part of Japan. Sapporo is here. Hokkaido University is in Sapporo. Sapporo Snow Festival is the worldwide famous event, but Sapporo Snow Festival became the first step to COVID-19 infection in Hokkaido and in Japan. Please see the black line, the graph as current number of patients. Governor of Hokkaido decided original emergency declaration in Hokkaido on February 28. He decided cancellation of emergency in Hokkaido on March 19th. This period is the first wave in Hokkaido. The period from emergency declaration to cancellation of emergency in Japan, this period is the second wave in Hokkaido. COVID-19 infection has settled down in Hokkaido too. In Japan, school and work year start in April. COVID-19 infection hit Japan directly in this March and April. Most of Japan activities such as education, business, medical care, sports, culture, lifestyle, and so on stopped in New Year. Graduation ceremony, entrance ceremony, spring events, and spring festival were cancelled. Motivation of people in Japan became very low. The spread of COVID-19 infection became serious in April. Japanese government banned the students of primary school, junior high school, high school, and university from attending school. COVID-19 infection has settled down after a busy period in Japan. Finally, New Year in Japan starts in June. However, the current situation shows delay of education, economic slump, collapse of medical structure, and change of lifestyle. I would like to show the influences to dental education in Japan in this situation. Number of university, school of dentistry, and dental college is 29 in Japan. 29 university, 11 national, 1 public, and 17 private universities. We investigated the current situation of 12 national and public universities. Each university began to control in March and banned the students from attending school in April. Result as follows. Lectures on schedule 7, delayed is 5. Phantom training on schedule 0, and delayed in 12. Clinical training on schedule 0, delayed 12. Clinical mutual training on schedule 2, delayed is 10. Training and experiments of basic dentistry on schedule 1 is 1, delayed is 11. We thought the influences was big and serious. We wanted to start from where we could right away. We had to carry out all lectures by remote. Lectures tend to catch up by remote lecture now, but all universities cannot offer clinical training in the hospital and phantom training. And I would like to show the problems of dental education in this situation. The photographs show normal situations of dental education in Hokkaido University. Problems of remote lectures. Lectures tend to catch up by remote lectures now, but there are some problems as follows. We cannot grasp reaction, understanding, and learning state of students, because we cannot get the student situation directly. It is difficult to evaluate grades. We cannot set an examination paper as conventional style in the current situation. There are some problems in internet environment. Problems of phantom training. We must change the training contents due to training time reduction. There is not enough masks and gloves for training, but recently supply of masks and gloves tend to return. It is difficult to avoid the 3 C's. 3 C's are closed spaces, crowded places, and close contact settings. But the environment of phantom training shows 3 C's. We cannot practice with all class members because the environment of phantom training shows 3 C's. Therefore, we must carry out the phantom training with each half of class, and then training time and manpower of teachers decrease. The shield of the training desk is necessary to the phantom training, but there is no shield in each university. Problem of clinical training. Clinical training is stopped now. Off-campus clinical training is cancelled. The student cannot get some learning opportunity from another angle. It is difficult to grow up the clinical skill of students. Simulator cannot complement some parts of clinical training in hospital. Programs of clinical mutual training. Clinical mutual training is stopped now. We must change the training contents due to training time reduction too. It is difficult to avoid the 3 C's. There is not enough masks and gloves for training. It is difficult to cooperate with simulated patients. A problem of training and experiments of basic dentistry. We must change the training and experiments contents due to training and experiments time reduction. There is not enough masks and gloves for training and experiments. There are some face-to-face training and experiments contents. It is difficult to avoid the 3 C's. We must provide the devices for training and experiments. The opportunities which the students try training and experiments themselves reduce. Infection prevention measures for training and experiments are not clear. And problem of others. We cannot grasp mental health and economic situation of the student well. The education of dental school has specific programs. Therefore, it is difficult to correspond by only business continuity plan (BCP) of the administrative office of the university. The students cannot learn clinical training in their university hospital. There are some isolated students. It is difficult to correspond to the second or the third wave of COVID-19 infection. Ministry of Education, Culture, Sports, Science, and Technology in Japan makes instructed flexibility of aggregate universities. But we have doubt that the students will be able to graduate with good condition now. The slide shows measures for preventing COVID-19 outbreak in Japan. COVID-19 infection has settled down gradually. Japanese government showed new lifestyle for preventing COVID-19 infection. New lifestyle is made up of 4 measures, such as basic infection prevention measures for each person, this orange part. And second, basic lifestyle for daily life, red part, and lifestyle for each scene of daily life, blue part, and new working style, green part. We think new lifestyle is good for the infection prevention. Wearing a mask, keeping a distance as station chairs, and the line to cash registers. We make effort to accept new lifestyle now. Basic approach is to avoid the 3 C's. But to avoid the 3 C's is not suitable for the dental education. It is difficult to control the environment of dental education as lectures and training. For example, lecture rooms and training rooms are narrow with to keep social distancing 2 meters. Therefore, we must provide the devices for lectures, training, and experiments of the dental education. The slide shows measures for preventing COVID-19 outbreak in Hokkaido University School of Dental Medicine. The first is hand disinfection at the entrance and wearing the mask. Lectures. Remote lectures are difficult to evaluate grades. We set an examination paper as conventional style due to understanding the knowledge of our students. We use 2 lecture rooms to keep social distancing with schedule control among some school years. Phantom training. Phantom training is carried out to each half of class. The students use masks, gloves, and face shield. We use desk shields to keep social distancing. These desk shields are handmade by us. We change the training contents due to training time reduction, and we strengthen the prior learning for phantom training with the video distribution of procedure and technique due to using the limited training time effectively. Clinical and clinical mutual training. We instruct the student to avoid the 3 C's as much as possible in clinical and clinical mutual training. We change the training contents due to training time reduction. We change the training contents. The students use masks, gloves, goggles, face shields, gown, and extraoral vacuum as aerosol measures. And we replace some parts of clinical training with simulator training. However, our university hospital does not accept the students now. School of Dentistry, Pharmacy, and Nursing are having a lot of trouble. Conclusion. This photograph is the end date of the clinical training of final grade students. This photograph. The students show happiness and relief. And this is the graduation ceremony of our School of Dental Medicine. It is the start of life as a dentist. We are teachers of dental education from now on. We should understand the current situation of our students and the problems. And we do our best to provide the good condition for our students with various devices, because people want to wait for birth and growth of good dentists. The photographs show the beautiful season in Hokkaido University. Unfortunately, we cannot enjoy our campus with our students now. We hope to return to normal situation quickly. That is all for my presentation. Thank you for your attention. Thank you.
Thank you. Thank you, Professor Yawaka. Is there any question from any place? Okay, actually I got a question from our audience. He's asking about, are private universities still doing lecture in Japan?
Thank you the question. Okay, can you listen?
Can you hear the question?
The private university, I don't know. I'm sorry. This symposium is very, we prepared time is very small, short. I contact a national university and the public university only, 12 university. But the private university, most of the private university is almost the same condition. And one of the some of the universities are very severe, and for due to the stop the infection, COVID-19 infection, and student safety is a very useful and a very good approach for in Japan. In Japan, the COVID-19 infection is settled down, but just now is not. I think not. And possibility of the infection to second or the third wave and near future. But I don't know. I don't want.
Okay, since we have a little, just a little time and we are a little bit delayed, so we would like to go to the next topic. If you have any question, please give your question online. You can give us the message and we will have the Q&A after the after talk. Okay. So we would like to go to the next speaker.
Morning. Could you hear my voice?
Yes.
Oh, good. So this is Sing-Chi von Bergman. Good morning. It's 5 a.m. here. Therefore, I am really, really honored to be invited by Professor from Taiwan. And this is going to be a quick presentations and overview of what has happened in dental education in Canada. This study was conducted based on my own personal interest, and there's no financial conflict. I was born in Taiwan, so there might be a little bit bias toward Taiwan. And because I am a professor at UBC, however, my positions in these presentations would not represent UBC. So overall, the objectives of this particular presentation is first to describe the COVID-19 situation in Canada. And then I will talk a little bit about the new reality that we faced here in Canadian dental education. I will present some of the findings in the scoping literature review that has just been completed and discuss a little bit of how we move forward. So COVID-19 has started in Wuhan, China, back in 2019, almost end of the year. In January, I went back to Taiwan for election purpose. And as soon as I returned, the first case has occurred in Canada. Of course, it's not because of me. So the January 21st, first case happened elsewhere, and in Canada, the situation becomes really severe only until March. So Canadians are quite fortunate in a way that the first wave Chinese outbreak didn't really impact greatly in Canada, and people were very surprised by this because we have lots of Chinese immigrants here in Canada. But after the spring break in Quebec province and Ontario province, we started to see a lot of cases, COVID cases. So with the genetic strains analysis that we found that a lot of the strains really are from Europeans strains. And so the mutations, the SARS-CoV-2 mutation rate is so fast that in some way that get transfer and impact various visitors of Canadians, and then Canadians brought it back, and sooner or later that it gets spread out. It got spread out within Canada. So here in BC specifically, that our health authorities recently released that most of the impact is really coming from March 5th through 7th, the Pacific Dental Conference. So this conference held early in March. You probably will think that is unthinkable. We have 7,000 of people who came to Vancouver for this major conference. For me as Taiwanese, watching COVID-19 news day in and day out, I have warned my colleagues that we shouldn't continue to proceed with this conference. This conference was not organized by us, but with 7,000 people coming to Vancouver for this conference, of course, large gatherings now we know will come to this particular situation, which is that many people contracted this virus. And as a result, we have one dentist that died from contracted COVID-19. In the past week, BC Health Authority released the genetic analysis, and it said majority of BC, nearly 3,000 cases are all germinated from this PDC conference. So on March 13th, UBC told staff and students that we would no longer have face-to-face conference meeting and teaching. All the teaching has to be online. As a result, on March 16th, our colleagues have to immediately transform into an online teacher. So many of you might agree with what I said below. Teaching is actually not something that you can learn overnight. So in 2 nights, not only that our teachers are expected to teach online, but our students are also expected to learn online. For students who are technology savvy, it's quite easy for them, but it's quite a challenge for our colleagues. So I will talk about that a little bit later. In this particular slide, you see various situations that occur, the COVID impact in this province. So Canada has 10 dental schools. And the reason that I show this particular slides, you can see that COVID impact Canadian provinces differently. But in terms of how we reported and communicated with the public, also vary. Ontario, in this particular lower part here, this is Alberta. Alberta's presentations very clear and clean. BC, in some way, decided to hire IT folks and replicate some interface, look exactly like Johns Hopkins. Ontario's presentations is all in PDF form, so it's not live, it's not interactive. And Quebec's presentation in many ways, because of its unique position, is in French. So in many ways, it's attempt to cover everything that happened in Canada in addition to what happened in Quebec. So as I said earlier, COVID-19 impacts our society, economics, healthcare sectors of Canada greatly, even though our case number is not as severe compared to a lot of our fellow countries like in US, also in Europe. The societal impacts here that in this particular slide, you could see the surge of COVID-19 deaths in long-term care home is very, very prominent, featured in all Canadian news. Even up to today, we still have a lot of discussions about what had happened. Have we left out our elders in our public health preventive measures? K through 16 education are badly impacted by this particular pandemic, and instructors struggle to really keep the teaching going, but in reality, most of our elementary school students really have just 1 day or 2 days online meeting with their teachers and peers. But most of the teachers really are not happening. Students get assigned to do just projects instead of learning with the teachers. So you could imagine that the preparation time for the teachers is quite limited. And as a result, our teachers really don't get enough of support to teach online. And it badly impacts on our students. We have parents who have to stay home to work from home, and then they probably have some time to spend with their children in terms of support them for their continue to keep their learning going. But we also have lots of parents who just simply do not have the knowledge skills to be able to support their children. And in addition to that, we also have parents who are frontline workers who just can't continue to work with their children. Apart from that, worrying about their own safety, whether if they will contract the virus and then returning home to impact their children also may cause a lot of learning issues. There's also a lot of report and discussions in Canada on the increased mental health issues due to the social isolations. The impacts on healthcare sectors. The non-emergency healthcares were interrupted due to COVID-19. In BC, on May 8th, the report had came out that it would cost $250 million this year and take up to 2 years to complete the 30,000 procedures that were postponed. So non-emergencies cannot be cared for, and the boundary between what is emergency and what is non-emergency oral health care is even more unclear to practitioners and to the public. This I will talk a little bit more because we recently finished a study interviewing 45 oral health care professionals, and they, in their interviews, they actually talk a lot about this unclear directions of whether if they can actually care for their patients or not. So there's a little bit Chinese here because I quite enjoy this particular phrase that Chinese has. It's called 上有政策,下有对策. So often in a pandemic time, you would like a government have very clear directions to help their people understand the severity, the situations, and what strategies they have. I call it 3S. And if none of this is very clearly communicated, then it is going to be really, really challenging for the people to really follow the directive. So in addition to that, if your citizens are not very clear and comprehensible toward the COVID-19 pandemic, then they won't be able to act responsibly. And if they can't act responsibly, then you will create a lot of burden on the healthcare system, which we all witnessed in the past few months. And as a result, casualties really cannot be preventable. Here is our, in response to the online teaching mandate that has fallen upon all of my colleagues, I took up the role because I'm a chair for my faculty's Assessment and Education Technology Committee, observing that my colleagues being placed in this particular situation, they have to immediately teach. I thought that it would be great to just put them into the learner's positions, and I immediately organized online modules and request and invited my colleagues to join these online modules. Using this online module, I helped them to learn our course management system, and then learn all these different kind of Zoom, Skype, or Microsoft Team, or our Canvas, which is a Microsoft Collaborate Ultra platform. So using this various online meeting technology help them to continue carry on their synchronous online teaching. There are also asynchronous online teaching strategies that various colleagues have already employed. So in these particular online modules, I call it professional development module or learning community module. They share with each other how they can actually conduct asynchronous teaching. So in addition to that, I always advocated to have an evidence-based approach in doing education. So I asked my postdoctoral fellow, Dr. Zhu, to try to review the literatures, and based on adult education and health sciences education, we found that there were in total 627 articles came through that is related to online teaching and learning. So in such vast amount of literature body, we at the end carefully screened through these literatures and found there's still 642 records that are critical to inform our online teaching and learning practice. With the 642, we have found that there are 7 major themes that's actually critical to inform our dental education practice. So these are the 7 themes. Majority of themes talked a lot about the new technology in online learning, teaching, and assessment. You could see just slightly more than a quarter of them. And the next big theme is on teaching and learning strategies. And teaching style or learning style. So various researchers talk and incorporate a lot of these adult learning theories on inquiry learning. So such as problem-based learning, case-based, and learning styles discussion mostly focusing on how you actually engage our learners using variety of formats such as breakout room or discussion forum in a way that you can have the hallway, right? The Zoom and Ultra both support this hallway discussions. Institutional approaches in online learning is the third largest theme that came from the 642 articles. Perceptions, beliefs regarding to online learning among individuals, 11% of the articles. Global medical education and international online or distance learning talked about 8%. And this is something that I would like to discuss further after these particular slides. So comparison between technology-based education and traditional teaching learning, then the last one is interprofessional learning and global collaboration through online. What I wanted to talk about is this particular themes. So since online teaching and learning is quite challenging for many of us, in some way, we can't afford to recreate the wheel. There are many, if you can see that from what we have found here, 642 different peer-reviewed articles have already discussed extensively on online teaching and learning. We must be able to farm some of these great lessons out of our colleagues. And so in some way, if there are already 8% moving toward that direction of collaboration, I would like to use the opportunity for us to really start the discussion of how international dental education community can work together to collaborate and help each other out. In the last slides, this slide came from Taiwan CDC. And in some way, you could see that the data that presented here is quite detailed in a way that I use these slides in many places to talk about how accurate data is important to instill the trust in people, because Asian countries in some way are quite rule bound. They are more inclined to follow the directives of the government. But in individualistic cultures, like in North America, we tend to just take the rules and regulations a little bit more at ease. That's the description that I would like to use. We follow it if we actually trust it. So if the government in this North American context want the people to actually follow the directions, and so that the pandemic, the coronavirus, can actually be under control, the government need to collect data, very accurate data. And this similarly for dental educations. If we would like to convince our colleagues who are biomedical sciences based to work with us and then support online teaching strategies that are conducive to quality online learning, then we need to collaborate to collect good data, to communicate with our colleagues that many of these good teaching learning strategies can actually enhance our students' learning. So in summary, for us to live well in this uncertain time, we have to support online teaching and learning, not just from the top down, but also bottom up, to create various learning communities, help our colleagues to talk to each other. And we also need to recognize the culture of certainty in dentistry. 2 years ago, my colleagues and I wrote a paper published in Journal of Dental Education, described this culture of certainty in dentistry in details. And it led to a lot of discussions among dental education scholars. And in our 45 people interviews, we found these big themes of anxiety incurred by the unknowns toward this pandemic. And these unknowns led us to ponder that there are known knowns, and there's knowns unknowns, and there are also unknowns knowns. So it is very complex. And if we wanted, we all know that our professions tend to have this, please give me some clear direction, please teach me, please help me understand these situations. Because to be able to deal with the uncertainties in various platforms make it very anxious in individuals. And so if the leaders in public health sectors or in government bodies or even in dental schools can clearly help our students, teachers, or the public to understand that yes, there are uncertainties, but we can go through this together. And here is what I propose to do. Then you can ease a lot of these anxieties incurred by uncertainty. So that's my presentation this morning or your evening. And I would like to thank my postdoctoral fellow. And thank you very much for listening to this particular presentation. And I wish that there will be opportunities that we can have a face-to-face discussion further in this very important topic.
Thank you, Professor
You're
Xinqi.
welcome.
I am
You're welcome.
ECK. Can you
Yes.
hear me?
Yes, I can hear you well.
Okay. I'm curious about, you have mentioned in your presentation, UBC now have the encounter the COVID-19 pandemic. So many of the class have online course. Do you have received any complaint from student parent, or your teacher about the online course?
So dental schools is very, thank you for the questions. Dental school is very hands-on education. Without the clinical practice in the past 3 months, it definitely invited a lot of discussions among students, among the faculties. Faculties try to figure it out how we actually help our learners continue to acquire their psychomotor skills. And students wonder when they would actually be able to return to campus and started their clinical practice. But without the proper personal protective equipment, PPE, the reason that I said that is because even until 2 weeks ago, what we learned is that we only have 75 N95 in our faculty. We only obtained 75 of them. And last week, we started to fit our students, our staff with this N95 in preparations of gradually returning to the clinical practice. So our students, only graduate students, only were just invited back this past Monday for clinical practice, but only 1 day a week. So if you think about online teaching learning, there's limitations on how you actually help our students to get the hands-on opportunities. It's not impossible. Other American universities have already started to try it out. If you were part of ADIA, you probably have joined some of the webinars on how you use virtual simulation to conduct a virtual OSCE, for example. And if virtual OSCE is doable, then it's possible to start to do virtual simulations in a much more meaningful way. Our students felt that the instructors have been trying very hard to learn how to teach online. Not all of them, but many of them. The understanding of these pandemic situations really have brought out a lot of sympathies in both the students and the professors. So the complaint probably or concerns probably is more sitting on, again, like I said earlier, the uncertainties. When can we return? And in what way can we practice safely without getting the disease? Did I answer your question?
Yes, thank you.
You're welcome.
Any question from our audience? Okay, because of time limit, I will move to the next section. Our next section, our moderator is William Zhang. Okay, William, please. Thank you, Professor Xin-Qi.
Thank you.
Okay, thank you, Professor Xie. And we would like to move to our next section. Our next section will be talked about by the Professor Kelvin Fong from National University of Singapore. He is a very important role in the National University of Singapore during this COVID-19, and he also was the president of the IIDR Southeast Asia Division. So his topic is how to conduct a summative high-stake assessment during COVID-19 efficiently and safely. So let's welcome Professor Kelvin Fong.
Okay, thank you, Professor Jack Chang, for this kind invitation to participate in the online symposium. Can you all hear me?
Yes, very clear.
Yes.
Okay, very good. Okay, so I'm going to continue. I'd like to share with you over the next 20 minutes a successful example of a summative high-stakes assessment from the orthodontics postgraduate residency program and how we conducted it effectively and safely during the partial lockdown in Singapore. My name is Kelvin Fong. I'm the program director for the orthodontics residency training program for the last 20 years. So this program of residency training is a 36 months, 3-year full-time coursework program. The summative assessment, we call it the final MDS orthodontics examination. MDS stands